It's Valley Focus, and I'm Kayla Mortellaro, your guide for the program, as we are joined by Dr. Jeffrey Langland, Ph.D. with Southwest College of Naturopathic Medicine, as well as a professor here with ASU. You are a professor, right?
Yes.
All right, there we go. COVID-19, and it's a hot topic. It's certainly circulating within our community, and it's something that we obviously need to be paying attention to here, and it's disrupted our lives. So what do we now know about COVID-19? It was a novel virus as it entered our communities back in March, and scientists are taking time to figure this all out. So COVID-19, it's definitely taken a hold of the community. What do we know now, and how it behaves, and what is more known about potential airborne spread?
Yeah, so, obviously, as you're mentioning, every day, every week, every month, we learn a little bit more about this virus. It has certainly taken our society and the world by storm and changed how we act day to day in and out of what we're doing. But, and as you said, one of the newest insights to come out of the virus, and it's not necessarily the virus has changed, but just our understanding of the virus, is that the mechanism of how we can get exposed to the virus has taken on a different route, and that being more that it could be possibly transmitted through airborne transmission. And so I think the first statement here I need to make is, how's that different? We all know that it can be spread by coughing and sneezing and those sorts of aspects. And that's what we term more as aerosol transmission, where the virus is carried by, when you sneeze or you cough, you release a lot of droplets from that sneeze that typically can travel about a meter, maybe up to about 6 feet at most. And that's why we have the social distancing in place for that aerosol transmission, that when we cough and sneeze, most of those droplets won't travel much past a meter. And so that's where we have that precedence in place. When we deal with the new aspects of SARS-2 here, the idea is that the virus may also be transmitted by airborne means. And what that means is, in a few viruses like this, like measles, where the virus is actually carried by more smaller droplets and more or less can be suspended in the air. And this can be spread more just by talking and not necessarily sneezing or coughing, but just really, as you talk, you're actually releasing these really microscopic droplets in the air. And these can stay suspended in the air quite a while and can travel much greater distances. And through recent laboratory investigations, as well as several incidences when we've investigated people getting infected by the coronavirus, there's definitely cases where we're almost certainly the virus is being transmitted by these more airborne mechanisms, where it's traveling much greater than 6 feet away. One case in particular was a person with COVID-19 got on a bus, sat in one area of the bus, and several other people got sick on that bus from that person. But some of those people that got sick were toward more the back of the bus. So, the virus traveled through that enclosed environment and got all the way back to, 20 feet away. And so that's more that airborne transmission.
That was going to lead into my next question, as we're joined here by Dr. Jeffrey Langland, Ph.D. with Southwest College of Naturopathic Medicine, as well as professor at ASU, talking all things COVID-19. When we're learning more about the airborne transmission here, a couple of factors. That 6 feet of distance that we've always been told is really important. It may need to actually be more than that if we're talking about it being kind of circulating through the air. And then the second part of my question there, are we learning that potential air flow because of an air conditioning unit is now pushing that airborne transmission further than maybe it would go if we were just outside?
And the answer to both your questions there is yes. And, I still think the major mode of transmission for person to person is probably, again, through direct contact, as, getting the virus on our hands and touching a doorknob, and another person touching that doorknob and touching their face, as well as these more larger droplets. But, there is this third aspect now where, especially in enclosed environments, the virus may be lingering in the air and can be transmitted much greater distances. And this becomes a concern for things like, classroom environments, restaurants, churches, office buildings and things like this, where you have people more in a confined space, and that virus may be lingering in the air much longer, especially when dealing indoors. The virus is much more stable in an area that's more of a moderate temperature, no UV sunlight irradiation, and the virus can allow now potentially linger in these air situations here for several hours. Outside the virus is still pretty unstable with our sunlight and the heat. The virus isn't traveling quite as far, but it's more of these enclosed environments that it's more of a problem.
And so when we're also talking about what we're learning from the virus, I guess it's good news, though, that on the surface, when the virus is living, like you talked about, on a doorknob or a desk or something like that, that if a Lysol wipe just comes right over it, it essentially kills the virus very quickly. So it's not lingering around on surfaces as well.
Yes, as long as we do clean those surfaces up. I mean, it surfaces outside with our, especially here in Arizona, with our high temperatures and UV radiation from the sunlight. It'll kill a virus pretty quickly on those surfaces outside. Inside, yes, as long as we're maintaining those practices of sanitizing those doorknobs or faucet handles, the virus can be eliminated pretty quickly there. And as well as just, common practices that if you do touch a doorknob, be conscientious that you're not just putting your hand back up to your face and potentially giving yourself that exposure.
Dr. Jeffrey Langland, PhD with Southwest College of Naturopathic Medicine, as well as professor at ASU, talking all things COVID-19 with us here on Valley Focus. There have been reports that the virus has mutated a bit, making it more transmissible, but not necessarily more deadly. So can you explain to us about mutations and then specifically what this research finding about mutations with the COVID SARS-2 virus means?
Yeah, so any microbe especially will mutate as it circulates throughout the population, and COVID-19 here is no different. It is mutating. It's not a rapidly mutating virus, so it's not like HIV. It's even less mutating than flu. It's thought to be about twofold less than flu mutations, that sort of thing that occur. So it isn't a rapidly mutating virus, but since the virus is replicating through so much of our population and replicating so many times, as the virus replicates itself, it makes mistakes. Those lead to mutations. Mutations can be negative, where it kills the virus. They can be non-consequential, where it doesn't do anything to the virus, or they can be positive, where it actually makes the virus enhanced in some ways. The majority of the mutations that have occurred, at this point in time, the virus is thought to mutate at a rate of about a few mutations per year. It's thought as the virus has about 30,000 of these Gs, A's, T's, and C's, and that sort of things in its genome. It's thought to occur at a rate of about 24 mutations per year. So that's pretty slow for a virus for the most part. Now, as far as the mutations that have occurred, majority of all these mutations that have occurred have been pretty much inconsequential. They're not really helping the virus. They're not really hindering the virus. They're more or less inconsequential. There has been one mutation that has been mapped that has allowed the virus to bind to human cells a little bit better than it was before. Again, it's not really making it more deadly. It's just making it more adapted to the human population. And it's more likely occurred that the virus is getting used to humans. If we go back to where the virus came from in China, it likely started from bats or these animal sources like pangolins, and it was used to replicating in those animals. It got into the human population, and it's adapted a couple minor mutations in order to be more adapted and transmissible from human to human, not necessarily making it more deadly. Because again, most viruses, bacteria don't want to kill humans. That's not beneficial. For a virus to replicate, it actually needs humans, so it doesn't want to kill humans. So the virus doesn't necessarily want to become more deadly, but as far as being able to be transmitted easier, that may be an advantage for the virus.
As we also talk about the virus itself and just kind of obviously it was completely unknown. It was a novel virus as it reached us in March here in the United States. But with more and more research, we're seeing things that this virus is doing to the body. And I was hoping you could maybe try to make sense of it, that, you know, some people end up getting so devastated they're on a ventilator needing support to help being breathe, to breathe. You have people then also suffering strokes and blood clots. You have people really having accelerated heart rate. Then you have people who have no symptoms at all, or just have lost taste and smell. Can you make sense of why there is such a wide range of how people get affected by this virus?
Yeah, that's a huge question. So what it comes down to, two different aspects that are really important for what you're stating right there, is the first one is the viruses invade our cells. And so for a virus to invade a cell like COVID-19 here, it binds onto a protein that's present on our cells. And we know that protein is what's called the ACE2 receptor. That protein's present on our lung cells, but it's also present on a number of other cells within our body, like endothelial, like the cells lining your blood vessels. It's present on other cells within your organs, this sort of thing. And that's more or less what's responsible for a lot of those other symptoms where, you mentioned blood clotting. The problem with that is, here again, the virus isn't only present in the lung tissue leading to respiratory problems, but the virus is able to infect the cells lining our blood vessels, and that's leading to damage of those cells, which leads to the clotting issues. So a lot of this diversity in symptomology is based on where the virus is going in each person's individual bodies. And, you know, we are different from each other. So one person may have the virus more localized to the lungs and not spread to other parts of the body. Another person may have it spread to multiple organs within the body and lead to those conditions. Now, the other aspect that you deal with is the immune system. People with very, very minor symptoms, a lot of that is due to their immune system just being really healthy, and their immune system finds the virus really quick, clears it out, and their symptoms are pretty minor because their immune system is so healthy and so strong, and they fight it off. Now, the immune system also has a negative aspect to it, that those people especially that the virus stays around, lingers on, and gets well established, especially like in lung tissue, the immune system can start developing what's known as a cytokine storm. And that's one of the biggest problems that's causing a lot of mortality, is the immune system actually kicks in too strongly in these patients, and the patients more or less go into shock because their immune system's going too strong toward the virus, and that's leading to all the pulmonary issues and the fluid in the lungs and this sort of thing, because the immune system's almost responding too much.
Dr. Jeffrey Langland, PhD with Southwest College of Naturopathic Medicine, as well as professor at ASU, talking all things COVID-19 with us. As we continue on in the quest for a development of a vaccine, I was hoping that you could divulge to us kind of what the difference between an mRNA vaccine versus taking a deadened virus and putting it into the body. I think you have Johnson & Johnson doing one thing, you have the NIH and Moderna doing another thing. So kind of walk us through the different aspects of those two vaccine types.
Yeah, I'd almost like to go even broader than that too. Right now, there's about 14 different vaccines that are in different levels of trials and this sort of aspect behind them. And, you know, these different groups are trying, since this is a novel virus, these different groups are trying different techniques of how to get those parts of the virus into the body that'll cause the best immune response to cause that vaccine and the immune response to start to memorize or recognize the virus so it can fight it off in future infections. So we're really just dealing with different techniques here. mRNA, we're targeting part of the virus and more or less like the map on how to build the virus, and taking one of those proteins out and being able to put that into our own cells, and the protein from that mRNA will be made, and then the immune system will start to recognize that and start to attack it. The current adenovirus vaccine vector, that's one where we are taking more or less a virus that doesn't cause disease, and we're putting parts of the coronavirus into it, not the disease-causing aspects, but more or less the outside of the coronavirus, putting that into this safe-like virus, and being able to administer that to people with the idea that this safe virus will look like coronavirus and you'll get an immune response to it, and that'll be the vaccine. So there's a number of different ways being attacked here, which is a good aspect. We're not putting all our eggs in one basket. It's really taking different approaches to see down the road, hopefully, which one will come out the best and give us the best immune response to be able to fight off this virus in the future.
And when you also talk about the development of the vaccine, there are several that are still in like phase 2, and then there are several that are in phase 3. And so my understanding here of phase 3 is you have a larger population of people that are entered into the trial, also differing age ranges, differing ethnicities, differing comorbidities or health factors. But then also it's supposed to be longer in length for a trial period, so you can see how effective it is in warding off the virus to see if this is going to be a strong vaccine or if there's going to need to be like booster shots or something along those lines. Correct me anywhere that I've been wrong there.
No, you're pretty much right on the money there. So, when we deal with clinical trials, they more or less go from phase 1 through phase 4. Phase 1 is just safety, not really looking for the ability of the vaccine to work or not. It's just solely safety-based. Phase 2 is that preliminary one where it's a smaller population, kind of just getting an idea, is this vaccine going to be likely useful or not, just kind of preliminary small group of people and see how it works there. Phase 3 is really the meat of getting a vaccine, hopefully in the next step out to the public, where you're dealing with exactly like you said there, more of a diverse population, people with different health conditions, larger population, letting the vaccine, because there's some ideas out there the vaccine may not give us long-term immunity. So it's looking at that aspect of how long-term is the immunity going to be with a vaccine, and do we need those booster shots with it? So it's really just mapping out a vaccine that looks good in phase 2, moving that on to phase 3, doing it more with our diverse human population and see how well it really works in that human population. From there, if it works in a phase 3 study, then phase 4 is actually when we do release it to the public. We continue to monitor it, but see how well it works in the whole population as a whole.
Dr. Jeffrey Langland, PhD, Southwest College of Naturopathic Medicine, as well as professor at ASU. I don't want to take up too much of your time, but I do want to discuss a bit here about the development of therapeutics. Obviously, we know a lot about remdesivir and convalescent plasma, but when I think of a therapeutic, I more or less mean of something that, hey, I've come down with a fever, I've identified that I have COVID-19, and I take a therapeutic, and it prevents me from my body going into overdrive and needing the hospital. So where are we in that type of therapeutic setting?
Really mixed. I mean, as you mentioned, remdesivir is probably one of the major allopathic drugs that's being used out there. It's a decent drug. It's more or less once you get hospitalized, it's given to a lot of patients there, as well as lots of times steroid injections as well, so you don't get too strong of an immune response. None of these are perfect treatments. They are mixed population, how effective they are. You mentioned the more or less antibody treatment, giving getting plasma from patients that have recovered from COVID-19, getting their blood and isolating the plasma, which contains antibodies, giving that to patients as a therapeutic as well. That's had mixed results as well. So as far as therapeutics right now, there's not a magic bullet. Continuing research is going on across the board. We here at SCNM, we're investigating many botanicals. We've looked at a lot of the historical botanicals that have been in use in the past, especially out of traditional Chinese medicine, and been used for like the original SARS outbreak that occurred in 2003, the MERS outbreak in 2012. Many botanicals were used for the treatment of those outbreaks. We've been investigating the efficacy of those botanicals, and we've, at this point, screened about 40 different botanicals that have this historical use. We currently have about 5 or 6 that are looking very promising, that have the ability to inhibit replication of COVID-19, at least in a laboratory environment. We're moving forward with characterization of those, and with the hope that we'll be able to create more of a natural botanical blend that can really potentially help patients to as preventative as well as a therapeutic once they do come down with the infection.
Dr. Jeffrey Langland, I greatly appreciate your time and expertise, and I hope you'll come back and have some more information for us down the road.
Love to.
Absolutely. Once again, that's Dr. Jeffrey Langland, PhD with Southwest College of Naturopathic Medicine, as well as professor at ASU, as you have been listening right here to Valley Focus.